webinar. My name's Gus. I'm a physio. I'm a strength and conditioning coach. I can recognize
This
some
meeting is
names
being
on the
recorded.
attendees list. So if I've met you before, hello again. If I've not, welcome to the webinar. Um, we basically put together this webinar because we've created a platform aimed at physiotherapists, healthcare professionals, strength and conditioning coaches, due to frustrations that we were having with physiotherapy practice in general. So ultimately, a while ago, we wanted to do lots of objective testing, and we were using lots of research papers to get the information from, and then using spreadsheets to input that, and then copying it into patient notes. And it was just really frustrating and annoying to use. And then, other companies start and valves start to bring out new equipment that allows you to collect more data, but lots of these companies charge a lot of money to do so. So we basically have created a process by which we don't need expensive equipment to collect testing data for people who work online or who don't have testing equipment in their work environment. It still allows you to test your patients either remotely or in clinic or at home. And then it ties that information to the exercise program. So you know that you're actioning the data you collect. One of the frustrations we saw lots of people collecting this type of data, but then nothing really happened with it. So that was basically the thinking behind Benchmark. And the process by which it works is to split these things into three distinct categories. So we're looking at outcome, performance, and process goals. So outcome goals are the ultimate end point. So with physiotherapy practice, it's typically function and pain. People can't do the things they want to do, or they have pain doing it. We then drill down a bit further. We look at performance goals, and they basically broken down into four key categories of range of movement, endurance, strength, and power. And then process goals are the things that we have lots of control over and we can action immediately. So those are the exercises or the interventions you prescribe to patients. So the the purpose of this webinar is basically to take that theoretical framework and put it into practice and show you how you would use this in a clinical environment. So when you log in, the first page you come to looks like this. It won't have any patients on it. But the process by creating a patient is very similar to any other platform. We just need some basic information, and rather than creating a patient from scratch, I'll just show you how it looks when you edit a patient. But ultimately, we're collecting basic information around demographics that we need to give expected scores. So we need sex, weight, and date of birth. And we've got a height measure in there if we want to calculate anything to do with torque or metrics similar to that. From there, we then need a little bit of information around the patient's injury. So when it started, what's wrong, and then finally their activity level, which is based off the NHS guidelines. So for those of you who aren't familiar, these are very similar to the World Health Organization guidelines, so they're worldwide. And ultimately, everyone should be doing 150 minutes of moderate intensity activity or 75 minutes of vigorous intensity activity per week, plus two strength sessions. So we rate their activity based on those guidelines. Once you've created your patient, you have a patient card here summarizing their key information. And then we're essentially working our way across these tabs of outcome goals, these symptoms, the performance goals, the key performance indicators across those four domains, then their programs. So for the symptoms tab, when you create a patient, they will be automatically emailed a form asking them to fill out their symptom score. And their symptom score comprises of two key domains. The first domain is their function. So the patient picks three activities and types in three activities with which they're having trouble, and then rates them on a scale of 0 to 10. So if I show you here, this patient, it's a real patient. I've obviously changed their information, but they put in running a local park run, walking to the shop, and going downstairs, and they rated their pain on this scale. So you just use the slider to rate their function before progressing to the next component, which is their pain. So we've got a three-dimensional pain scale where we look at how often they're getting pain from constant through to never, how bad their pain is. So the classic numeric rating scale or visual analog scale, and how long it lasts for. So is it lasting for days or seconds? From this, we take an average of both of these scores. So the average for both of these was 4 out of 10 on their function score, 3.3 out of 10 on their pain score. The more useful part of this feature is this graph here. So as soon as you submit your results, it will plot them on this graph along with the projected function. So if I just hide the pain score here, you can see this projected function is shown over a 12-week period. So this is based off studies looking at the patient-specific functional scale, and we're taking the information there and basically plotting it on a graph. It's very vague, so we're using these as a really rough guide, but it gives the patient an idea of roughly how long this process is going to take. It also highlights the minimal clinically important difference. So this is the point at which the patient should notice a change in their symptoms. So considering we collected this information on February the 2nd, by April the 3rd, we would expect there to be a change in the patient's symptoms. And this is helpful for setting like realistic timeframes, realistic objectives. And if the patient comes back in February the 9th, a week later, and says there's been no change, this can be quite reassuring to them that it's completely normal for them not to feel a change yet. For the pain score, we're using a custom scale, so a three-dimensional scale, meaning we don't have enough data yet to start projecting improvements in pain. But the more data we collect, the more we can feed that back and create these feedback loops. So the outcome goal is the function and the pain score. We're looking to, that's the ultimate end point. And this allows us to, one, collect that information easily, two, to follow up and see changes over time, and three, compared to what would be a normal progression. So once we've done that, the thing it won't do is tell us what to do. So if a patient has reduced function and high pain, it won't give us any information on what to do. And that's ultimately the kind of cornerstone of Benchmark, of it allows us to test across multiple domains. These domains, as I said, are range of movement, and that's ultimately how far can the patient's joint move? Can they get into positions that they need to for their activity or sport? And can they dissipate those forces over a large area? The endurance score is ultimately, can they sustain force for a long period of time before they start to fatigue? Strength is the ability to produce high forces and deal with high forces. And then power is the ability to do that quickly. So whether that's if you're a foot correction or you're 85-year-old, I've just seen a question from Lydia, and I will come to this at the end of the session, or try and answer it during. But if the ability to produce force quickly is not only relevant for people who are athletic, but if you've got an older patient who is at a falls risk, they need to be able to catch themselves quickly. So all of these metrics are useful across different patient populations. In this section, you have the ability to add tests. When you add a test, you select the body part or body parts, and then you have a list of tests across these four domains. So we can test range of movement, endurance, strength, and power. The range of movement tests I tested using a phone-based inclinometer. And based off the research that we've used in this platform, the phone-based inclinometers are much more accurate than goniometers. They can also be downloaded for free on either iOS or Android. And in the protocol section, which I'll come to later, we've recommended specific apps. This means you can test your patient yourself, or you can get them to download the app for no cost and test themselves at home. Um, they can test their range of movement. You can test their endurance through just how many reps they can do of specific exercises or how long they can hold a position, for example, a plank. The strength testing, unless otherwise stated, is via handheld dynamometer. But for example, if I take off this one, we'll see that for strength scores around the knee, we can use a single leg um, leg extension machine, a single leg curl, a squat, or a leg press. So we've got isolated and compound movements. So once you've created your test battery, again, I'm just going to edit this rather than create one from scratch. It will give you an estimated time to complete these tests. And then you simply just type in the numbers that you see on your device or the number of reps that you count. For the strength testing, in this case, I've chosen to use a leg extension machine because this was a patient I worked with remotely. Once you type in the number of reps and the weight used, it will calculate an estimated 1 rep max, and that's the number we'll use to compare to normal. So when you submit those results, you'll end up with a table that looks like this. So you've got the test in the left-hand column, the unit that we use here, the expected value, and then the left and right values. We can also change between percentage and absolute scores. So for patients and for myself, I find it significantly easier to compare results when looking at percentages because I can immediately see that these 3 tests are the lowest, whereas I don't need to worry too much about flexion and their quad strength or single leg extension strength. And these are all color coded for ease. And we use these thresholds to determine the colors of each test. So red is less than 75% of expected, orange 75 to 99, and 100 or over would go green. So it allows us to then really quickly visualize which are the key tests we want to look at. If you've ever tested a patient, you'll get fairly predictable questions. The first question is always, is that good? So hopefully with the expected score, you'll be able to answer that question pretty quickly. The second question is usually, which test was that? Because I've just given this person 6 tests to go through. So to answer that question, we can play a hyperlinked video of what the test specifically is. But for your own purposes, if you want firm test protocols, they're in the protocol section here, which I'll get to later. And most of the protocols are on YouTube. So if you want to share the protocols with patients through your exercise prescription app or via email, you can do. And then the protocols are there visible for them as well. If you scroll down, you'll be able to visualize all these tests in a single plot. This is useful, again, to visualize the tests, but it can be a really good tool to share with consultants or other key stakeholders within a patient's care. And then the tooltip here, I find is quite a useful feature in that it will show both the raw score and the percentage score, but also the reference from where that data was taken. So here we can see that reference was taken from Peters 2011. When we go to the reference list, we can look up the full reference, copy and paste into Google Scholar. And if you've got an interest of why we're using phone-based inclinometer, you can read that that was by far the most reliable of the 3 methods they used. So that kind of covers the outcome goal and the performance goals. So from here, we're looking at the performance goals of knee extension, single leg sit to stand, and single leg hamstring curl. The benefit of this is that we can create a program purely from the patient's results by clicking this button. So when I then click on program, I can see, I'll delete these because this is what I did earlier. But if I get rid of all of these to demonstrate, when you click on create a program from these results, it will automatically generate a program based on the results that we've selected. So I want to look at knee extension range of movement, knee endurance, and hamstring strength. This then will generate a program from those. So I've got passive knee hangs to improve their knee range of movement. Their knee endurance will be improved by basically doing a test, and their hamstring strength through hamstring sliders. Now, your patient might not agree with that exercise. It might not be suitable for them. It might be too hard. It might be too easy. So we've got these progress or regress buttons. So I can progress through these exercises. If I don't want to use that feature, I can essentially select from this list of exercises that go from completely passive, so a therapist assisted movement, through to isometric, assisted, and then eccentric movements before a concentric movement. If none of those are useful, then I can just type in a completely different exercise, set my own parameters, and then link any YouTube video I want and put in specific instructions here to convey what I need to the patient. But if you do select from the existing ones, these parameters are already pre-filled. So for the vast majority of range of movement exercises, you're going to see 2 sets of 30 seconds 5 times per week. If I want to add, I might pick another one. It preloads all of this. I just need to enter something into here before clicking submit. And then you'll see that it's added that to the knee range of movement into extension. The number of sets is based off this information here. So I might not actually be too concerned if I've got quite a high dose here because it's only range of movement exercises. But if I'm getting up to 20, 30 sets a week on an endurance or strength exercise, I might need to rethink how much I'm giving the patient at a single time. So it's very easy to progress and regress exercises. When the patient clicks on this, they'll see a video, so it should be fairly clear on specifically what they're doing for each exercise, so they know how to execute it, the number of sets, the number of reps. The load will be usually set based on reps in reserve. So this we're aiming for 15 reps with 3 to 5 reps in reserve, meaning that if the patient hits 15 reps easily, they may need to add a dumbbell or a weight to make that harder for them. And then the same is true for the strength exercises. If there is a test that's not in benchmark, for example, we find that this patient has got a 3 or 4 centimeter deficit in their thigh circumference, we might need to add a completely different exercise, a different test. So we might do BFR, leg extension on one leg, and then we can set all these parameters ourselves to fit with what we want to do. So I know that this patient's 1 rep max is about 30 kilograms. That means 6 kilograms will be about 20%. I can add a video in here and I can add instructions before clicking submit. And we can ultimately add as many exercises as we want to into this new block. So then we've covered off the outcome goals, the things that we want to change for the patient, i.e. their function and pain, their performance goals, what are the key performance indicators that are going to contribute to that outcome, and then the process goals, what are the things that they can do to shift their performance goals to then push their outcome goal higher. Once we've done that, you're going to probably want to know if has that changed anything. So then we have a test comparison tab. The dates will reload depending on when you saw the patient, and then you'll be able to select any tests that were done on both of those dates. So in this example, I've just used the objectives where can we increase knee range of movement into extension? Can we change their endurance? And can we change their hamstring strength? So when you plot all of this on a single graph, it gets incredibly cluttered. But we know this patient only had a right-sided issue. So this is really the side of interest. So we can then filter just based on that right side and look at, they used to be at around 50%. And overall, they're now somewhere between 75 and 92%. So we know the performance indicators have changed positively, i.e. the exercise program we gave them has changed what we wanted it to. But ultimately, the real question is, has it changed their symptoms and has it changed it at a rate that we would expect? So the recommended time between these two dates is ballpark 6 weeks. You can do it more frequently or you can do it less frequently, but to pick up any kind of change, 6 weeks is about the optimum time. And here we can see there's big changes in the function score and big changes in the pain score, and that's actually quicker than the rate that we would expect them to change at. So that creates our feedback loops of what are we trying to change? How do we break that down into things that we can measure? And how do we affect those core components? And how do we track it over time? The other component of this is the what, why, and how of objective testing. And most of that information can be found in the protocol section. So to ensure that you're testing the same each time, and we're collecting all of this information, so we want to know that everyone's collecting data in the same kind of fashion, we've standardized all these protocols and made them as transparent as possible. So for all of them, we'll have a video, which is the easiest way to get an overview of how to do the test. But then you may want the specifics. So how many reps you can do in 30 seconds, the protocol of the specifics of the test, and then again, where we took the protocol from, in order to get a really clear idea of the test. I know a lot of people use a similar test for knee extension, doing single leg sit to stands and doing as many reps as they can. This was built with physios in mind who work in clinical environments, meaning that if we can do something quicker, we will do it that way if it doesn't compromise quality. So we know that both of these tests, as an AMRAP or as many reps as possible, and a time constrained test, are both equally reliable. So if we can make sure that the test is done within 30 seconds, it's going to be quicker than doing as many reps as possible. The other components of this left-hand panel basically span up and down. So as I said, this will be your start page. We also have a recording feature. So for anyone who uses AI within their clinical workflow, will probably be familiar with HIDI. This tool is similar to HIDI, and for those of you who don't know what that is, it's ultimately a audio transcription tool. So you set the tool up at the beginning of your session to record, and then it will transcribe the session and write it up for you. So what I usually do is do this at the end. I just dictate my notes. I then get the transcription. I can then create a SOAP note from that. So subjective, objective, assessment, and plan. So it takes me about 1 second to create that. And then I can create a patient summary, which I will copy and paste to the email just to reinforce what I've explained to them during the session. I can also create an onward referral if I want to. And that's within the recording session. So when you click on there, you'll have all your patients within that, and you can just click on their card and add recordings to their profile. I've mentioned the reference list already, and I'll come to exercise prescription shortly. But other features within here, business information is essentially for people who work within a clinic that has more than one physio. So if me and Mike both work at the same clinic, we might want to see each other's patients. So if I log in and save a patient, Mike then may see them in a couple of weeks' time. It means that he can then log in, see that patient's information without me having to copy and paste into different areas. Once you've created your business, you basically add users to that business, and you can have as many users as you like. In terms of subscription, we offer everyone a 28-day free trial. So if you want to give it a go, but you don't want to commit to a fee, then you have 28 days to test it out. So you either test it on yourself, test it on a couple of patients, and see how you get on. And for the purposes of this webinar, we're offering the first 40 users a cost of £5 per month on a rolling monthly subscription. So if it's something that you're interested in, it's much cheaper if you sign up in the short term rather than the long term. And then in terms of other components, I just wanted to mention exercise prescription. So a lot of the features are built in. So when you prescribe exercise, it will help you in terms of sets, reps, load, frequency, all based off current training guidelines. But if you've got people who are particularly inactive, which will happen, people come in, they don't really do any training. We've got tips on how to try and increase their activity levels by not giving them lots and lots to do in a single go. This can be useful to promote exercise in these inactive individuals. And then conversely, using the opposite in where you've got someone who's really keen, triathletes or habitual exercises. We often see that a lot of their problems are due to this imbalance between stress and recovery. So these tips can help you build out more sensible workloads. Even if they're still going to train every day, we can make that much more efficient by alternating between high load, low load days or high intensity, low intensity days. And then finally, the most useful component on here, in my opinion, is the one regarding block periodization. So if we use the same example as before, and we look at the results of this patient, the first time they came in, we've got on this right knee 6 deficits that we potentially would want to change at the same time. That's going to be a minimum of 6 exercises, and realistically, it may be up to 18 if we're doing 3 exercises per adaptation. And we know that by giving someone 18 exercises, it's simply not going to get done. And then we're caught between this rock and a hard place where it's like, well, I need to change these things for this patient, but I only have a finite amount of exercises I can give before they're going to stop doing it. So our suggestion here is to look at the research and say, okay, people who are prescribed 4 or more exercises will obviously have lower compliance compared to those who do 2. But also for those who only do 2, they show better outcomes in their performance measures and their patient-reported outcome measures, particularly than those prescribed 8. So an effective strategy to mitigate this problem is basically creating a roadmap for the patient, which in S&C language, people would talk about periodization. This is essentially just a very fancy and complex way of saying organized training. And block periodization is essentially just organizing that training into different blocks where you would work on one specific block first, which would then lay the foundations for the next one. The way I typically orientate this will be in this direction. So we'd say, firstly, we need to increase your range so you can dissipate these forces across a large area. Once you can dissipate those forces over a large area, we want you to be able to sustain those forces for long periods of time. And the reason we want to do that first is because it typically involves lower loads. Once your progression to the next phase is contingent on you ticking off your scores or your targets for endurance. Before progressing to a strength block, where we're going to try and increase the ability for you to produce high levels of force. And then finally, we want you to be able to access that force very quickly. This means that you can really focus in each block. The patient still feels like they're making progress because they've got a specific objective, and they're far more likely to tick off that objective because they've got far less to do. That is a very quick summary of the core functionality of Benchmark. There's a couple of questions in the chat, so I'll just address those now. So the first one is, which instruments are we using to collect the scores? So for range of movement, I'll show you an example of a range of movement test. So all of them will be using a phone inclinometer, and specifically fast goniometer, rate fast for iOS or ankle meter for Android. There's loads of different variations, but these are the ones that we found the easiest to do. For endurance, it depends, but typically it's a AMRAP or as many reps as possible. So for example, with the calf raise test, it's just how many calf raises you can do at a specific rate. but that does vary. So if I go to a shoulder test, we've got a posterior shoulder endurance test here. Um, so by lifting you take 2% of the patient's body weight, get them to hold that for as long as they can. So these can be done remotely, they can be done in person, and they require very minimal equipment. Next question was, do you have at-home standardization instructions? So yes, here. There's a video that you can share with the patient, even on things like the athletic shoulder test, which typically is used by a handheld dynamometer. I do quite a lot of remote programming, and I just use bathroom scales for this test. And as I said before, we use a lot of gym-based tests. So for you can see here that we've got kneeling one arm landmine press, one arm, so a horizontal and vertical push and pull in the gym, and then a horizontal and vertical push and pull using a bilateral and a unilateral version. I have found that to be I found any of this to be motivating for patients. So one of the big things for patients is being able to see progress. And that can be really difficult if you're the patient and you're with your pain every single day. It moves at such a slow rate, you don't notice it change day to day. But if you can say, okay, we've measured your symptoms at the beginning, we've measured it at 6 weeks, and you're progressing faster than we would expect. We've also measured your range of movement, your endurance, your strength, and your power, and they're all progressing, especially with the gym-based tests. Every session they do, I will program in a test. So, for example, if I've got a knee patient and their knee extension is low, at least once a week, I'll get them to do a single leg knee extension, and I can test their results. I can test them each week, and they can see their results increasing, i.e., their estimated 1 rep max. At the moment, there isn't a process to copy into note systems. The best option we have is either linking the URL or screenshot results into the note software. The only other thing that I do is when I take all my notes via audio transcription, and I will ultimately talk through the results with the patient. So then it will record it all in the transcription tool, and I'll copy and paste that into the note platform. All the data is stored in Render, which is a worldwide database. So that's compliant with GDPR, HIPAA, and whichever the version of that GDPR is relevant for the EU. So there's very few countries in which that Render's not a suitable place to store data. Cool. For anyone, so if that's a basic summary of what we have. For anyone who has questions, I'll stay on the link if you want to ask specific questions. Conversely, Mike has posted I'm just checking, we'll post my LinkedIn in the chat. If you've got any specific questions you don't want to ask in here, you can message me on LinkedIn. You can message in the chat, or if you don't have any questions, then that will be the basic summary for today. But thank you for your time. And as I said, I'll stay on the link in case anyone has questions.